Good afternoon, everyone, and thank you for the opportunity to present an interesting clinical case that we saw as a consult from General Medicine at Rudolph. Our patient is a 29-year-old man. He is a father of two who lives in Atlantis. He moved from Zimbabwe to Cape Town 13 years ago. He has no known medical comorbidity and is HIV negative. His symptoms started 2 months prior to this presentation, and he reported diarrhea that was associated with fever, vomiting, and night sweats. Further history, his symptoms started with diarrhea, which had no blood or mucus in the stool, which progressed during his travel to Harare 10 days later. After he returned to Cape Town 2 weeks later, he developed fever, vomiting, and night sweats. He presented to the local clinic and was given paracetamol and ibuprofen. Apart from these analgesics, he denied taking any new medications, toxins, vitamins, or over-the-counter medications. He worked as a gardener on a farm in Atlantis, and no animals were kept on that farm. He denied consuming unpasteurized milk, and there was no history of tick bites. On arrival at Rudolph, he was alert but disoriented. He appeared deeply jaundiced and had a flattened affect. His vitals were normal. Abdominal exam revealed a 16-centimeter non-tender hepatomegaly. He had no conjunctival hemorrhage, and no skin lesions or eschar was found on examination. Here are the initial investigations. As you can see, the full blood count showed a progressing pancytopenia. The diff count is not shown here, but showed a predominant lymphopenia. There was no red cell fragments on peripheral smear. He had significant renal impairment and hyponatremia. He also had acute liver injury with a conjugated hyperbilirubinemia and a mixed LFT picture showing both transaminitis and cholestasis. And he had of concern a rising INR. The initial workup was done. Viral hepatitis A, B, and C were all negative. A malaria film was performed and no malaria parasites were observed. A blood culture was done prior to giving empiric antibiotics, which was negative. Abdominal ultrasound showed hepatosplenomegaly with no focal lesions in liver or spleen and no intra-abdominal lymph nodes. So we were consulted at that point by the medical team to review the patient. And the differential diagnosis for this case was brought, which included bacterial, viral, rickettsial, and parasitic infection, as well as non-infectious causes. Febrile gastroenteritis is a common clinical feature of typhoid fever and non-typhoidal salmonella. Although extraintestinal complications are uncommon, they can occur with delayed presentation. Leptospirosis can present with a rapidly progressive multi-organ illness with fever, jaundice, and renal failure, a syndrome known as Wells disease. Patients with brucellosis can present with prolonged fever with abdominal pain and hepatitis, but there was no clear risk exposure. Disseminated tuberculosis had to be excluded given the history of constitutional symptoms and the presence of hepatosplenomegaly. Malaria was not ruled out yet with a single film, but the duration of illness didn't fit. The duration of illness didn't fit arbovirus as well, and most patients with dengue will present acutely. Hepatitis E infection had to be excluded, but the mixed picture on liver function test was not typical. Patients with rickettsiosis can present with prolonged fever with multi-organ involvement, but there was no skin rash or eschar found on examination. We also considered non-infectious causes, including toxins, hematologic malignancies, and autoimmune disease. So this was a diagnostic conundrum, and we narrowed down to 3 major schools of thoughts before a diagnostic test was performed. A stool was sent off for analysis, and we received a very exciting message from our microbiologist, which put all of us out of our misery. Stool microscopy showed inflammatory picture, and Salmonella type B was isolated on culture. In summary, this is a 29-year-old man, HIV negative and previously well, now presenting with typhoid fever, complicated with hepatitis, acute renal failure, and cytopenia. So I'm going to be talking about typhoid fever today. I learned a lot about the topic while reading on it, and I thought it was very interesting because many patients with typhoid fever present with non-specific clinical features, and this case was a diagnostic conundrum. So I think it is an important topic to discuss. Typhoid fever, also known as enteric fever, is caused by Salmonella enterica serotype typhi and serotypes perityphi A, B, and C. The name typhoid means typhus-like, which reflects the difficulty in differentiating this illness from epidemic typhus caused by rickettsial infection, which was a common cause of prolonged fever in Europe during the 19th century. Salmonella typhi and perityphi A and B are human restricted, and there are no animal reservoirs. Infection of typhoid is most often acquired through ingestion of fecally contaminated food or water. Typhoid is a major global public health problem. Estimates of new cases range from 22 to 27 million per year. The highest burden of typhoid fever is in South Asia and parts of sub-Saharan Africa. But the true burden of disease is massively underestimated by the lack of surveillance in many regions and low sensitivity of current diagnostic tests. Clearly, all of these would be fixed if we improve our water supply and sanitation, it being a fecal orally transmitted illness. Interestingly, there is not an association between typhoid and HIV, whereas we know there is an association between non-typhoidal salmonella and HIV. So with the rollout of antiretroviral therapy, incidence of non-typhoidal salmonella has gone down, but replaced in many areas by Salmonella typhi predominantly. Salmonella typhi pass through the intestinal epithelium by invading specialized epithelial cells called M cells. They then enter the Peyer's patches where they multiply in macrophages. It then leads to its transport to spleen, liver, bone marrow, and gallbladder, where the bacteria continue to multiply in reticular endothelial cells. Once a threshold is reached, usually after about 7 days, bacteria is released into the bloodstream. It is during this bacteremic phase that patients develop fever and blood culture becomes positive. Bacteria seeds to other organs, leading to extraintestinal manifestations. Salmonella typhi can also persist in bone marrow and gallbladder for life and reseeds to mucosal surface, shedding out into stool, which is important for the transmission of illness. The clinical features of Salmonella typhi are non-specific. Fever and other flu-like symptoms, including headache, myalgia, lethargy, are common early on. A non-productive cough is a common feature. Abdominal symptoms can include diarrhea and constipation. Relative bradycardia is a classic feature of typhoid fever. Hepatosplenomegaly, if present, is usually modest, and raised ALT/AST above 2 to 3 times the upper limit of normal is common, but severe liver involvement with clinical features of acute hepatitis is rare. In a case series of over 470 patients with typhoid fever in Pakistan, 11% were diagnosed with typhoid hepatitis. And importantly, 4% were initially misdiagnosed as viral hepatitis. In this cohort of patients, typhoid hepatitis occurred more commonly in men. Based on findings from the study, typhoid hepatitis should be considered as a differential diagnosis in patients presenting with fever, jaundice, and hepatomegaly, especially if the LFT shows a conjugated hyperbilirubinemia. Bone marrow culture has the highest yield, likely because Salmonella typhi persists for a prolonged period in the bone marrow, and liver biopsy in this case series showed non-specific changes. Reported incidence of typhoid hepatitis varies widely between 1 and 26%. Predisposing factors are higher virulence of the organisms, delayed treatment, anemia, and malnutrition. Seeing a typhoid nodule on liver biopsy, which is essentially hepatic granuloma, which is shown in this picture here, with Kupffer cell hyperplasia is characteristic. And liver biopsy may help to differentiate typhoid hepatitis from viral hepatitis. Despite severe liver injury, prognosis is generally good if treatment is started early. Jaundice and hepatomegaly usually resolves within 2 to 3 weeks of effective antibiotics therapy. Because many clinical and laboratory features overlap, typhoid hepatitis is often mimic viral hepatitis. In this retrospective case control study, comparing 27 patients with typhoid hepatitis with 27 cases with viral hepatitis, a significantly higher proportion of patients with typhoid hepatitis had high fever above 40 and relative bradycardia compared to patients with viral hepatitis. And interestingly, an initial ALT to LDH ratio was significantly lower in patients with typhoid hepatitis. As you can see in this graph here, the little triangles represent cases with viral hepatitis, which had an initial ALT-LDH ratio above 5, whereas the little rectangles represent cases with typhoid hepatitis with an initial ratio below 4. Patients with typhoid fever can present with life-threatening complications, including intestinal hemorrhage and perforation, as shown in this picture on the right. Patients can also present with shock and profound encephalopathy. A small proportion of patients develop chronic asymptomatic carriage, which is defined as shedding of Salmonella type B in stool for more than a year. The picture on the right depicts typhoid Mary, who was associated with repeated outbreaks of typhoid fever in households in New York, ultimately leading to her lifelong quarantine. Without treatment, 10 to 15% of patients with typhoid fever die, but effective antibiotics therapy reduced mortality rate to 1%. Current diagnostic tests for typhoid lack sensitivity and specificity. For this reason, it is appropriate to start patients with suspected typhoid fever with empiric antibiotics. A definitive diagnosis is only made by isolation of Salmonella typhi from clinical specimen. Blood culture sensitivity range from 60 to 80%. The low-grade bacteremia is a major limiting factor in the sensitivity of blood culture. To maximize yield, WHO recommends performing blood culture using a minimum of 10 to 15 milliliter of blood. Culturing stool has low sensitivity, but increased diagnostic yield by 5% if used together with blood culture. And culturing bone marrow has the highest sensitivity, but is clinically impractical for most patients. The Waddell test is the first serological test developed for to diagnose typhoid, which is essentially an agglutination assay that detects the presence of antibodies against the O and H antigens. Its use is limited because past infection or previous exposure to cross-reactive antigens or even vaccination can lead to a false positive result. So most people with living in endemic settings will have a positive Waddell test. In patients presenting with severe typhoid requiring hospitalization, effective antibiotic therapy, good nursing care, appropriate nutrition, and correction of fluid and electrolyte imbalance are essential to prevent death. There is strong evidence that fluoroquinolones are the most effective drugs for treatment of typhoid fever. However, that's offset by toxicity of fluoroquinolone and emergence of resistance. In our setting, third-generation cephalosporins such as ceftriaxone or azithromycin are effective treatment for typhoid fever. For patients treated with ceftriaxone, fever resolves within in 1 week on average, and treatment failure rates are 5 to 10%. For patients presenting with intestinal perforation and hemorrhage, emergency surgery is required. And for selected patients presenting with shock or profound encephalopathy, dexamethasone use has shown survival benefits. Patients with typhoid should be isolated and nursed with contact precaution, and treatment of relapse is the same as for initial infection. This graph shows the gradual emergence of antimicrobial resistance, which limits the use of effective antibiotics in many regions. Chloramphenicol resistance was reported just 2 years after the antibiotics was first used for typhoid fever. Multi-drug resistant strains with resistance to chloramphenicol, ampicillin, and cotrimoxazole became common in the 1980s. And in 2016, an outbreak of XDR strain was reported in Pakistan with additional resistance to third-generation cephalosporin and fluoroquinolone. Typhoid is such a major driver of antimicrobial use in endemic settings that vaccination to reduce incidence of typhoid fever may have a significant impact on antimicrobial stewardship in those settings. Most recently, a new generation typhoid conjugate vaccine have become available, which contain the VI polysaccharide conjugated to a tetanus toxoid protein carrier. In this phase 3 double-blind randomized controlled trial, a single dose of this typhoid conjugate vaccine was both immunogenic and effective in reducing the incidence of culture-confirmed typhoid fever in children between 9 months and 16 years of age. Vaccine efficacy against culture-confirmed typhoid fever in this clinical trial was above 80% at 12 months. Back to our patient. He completed 2 weeks of intravenous ceftriaxone and had marked clinical improvement. This table, as you can see in this table here, his creatinine and liver enzymes peaked on day 4 and started to improve from day 6. On this chart, his renal function and liver function have returned to normal. Platelet count has recovered. His white cell count and hemoglobin remained low but stable. So in conclusion, recognizing extraintestinal complications is important in preventing the delayed diagnosis of typhoid fever. And importantly, early effective antibiotic therapy reduced mortality rate from 10 to 15% to 1%. Typhoid hepatitis should be considered as a differential diagnosis in patients presenting with fever, hepatomegaly, and jaundice, especially if the LFT shows a conjugated hyperbilirubinemia. And lastly, making a definitive diagnosis of typhoid fever is challenging. Culturing of bone marrow has the highest sensitivity, and taking a large volume peripheral blood culture helps to maximize detection. Thank you.